Jean-Luc Monin will now show us how to assess subvalvular aortic stenosis. He will show us that it requires a careful examination of the valve, of the subvalvular area, but also of the aorta and of the left ventricle. Afterwards, he will move to the use of color Doppler to detect the site of obstruction and eventually a presence of aortic regurgitation. And finally, he will show us that we have to use color Doppler, but also Doppler, to quantify the regurgitation and eventually the obstruction.
We will now perform the echocardiography of a young patient, 34 years old, who has subaortic valvular stenosis and who is strictly asymptomatic for daily activities. And as usual, we will begin with the parasternal long axis views in order to image the aortic valve, left ventricular outflow tract, and also the aortic root. So as you can see on this first view, the aortic valve seems to open normally, and there is some kind of abnormal structure here, thin structure, membrane, in the left ventricular outflow tract. Afterwards, we will perform, as usual, the M-mode measurements on the aortic root and the left atrium. Here is the line for these M-mode measurements. And here we stop the frame to perform the measurements. And as you can see, at the level of the sinuses of Valsalva, the anterior-posterior diameter of the aorta is 37 millimeters, which is normal. And the left atrium is 35 millimeters, which is also normal. The next step is to go one intercostal space upper here to image the aortic root and to have the tubular portion of the aortic root. We stop the image in diastole, and the measurements will be done from leading edge to leading edge. Here we have on A the Valsalva sinuses, 35 millimeters, the sinotubular junction on B, and on C the tubular portion of the aorta with an antero-posterior diameter of 39 millimeters, which is normal for this young boy. Now we will perform the M-mode measurements of the left ventricle, and we will align perpendicular to the long axis of the left ventricle. Here we can control that the line is really perpendicular to the left ventricular long axis. And you can see that the interventricular septum in diastole is around 9 millimeters. The end diastolic diameter for the left ventricle is 53 millimeters, which is normal. And the fractional shortening is 35%, which is also normal. Usually, it is useful to check the internal diameter of the left ventricle on a bidimensional view. And here, the checking of the measurement shows 55 millimeters, which is within the normal range for a boy of this size. Then we will measure the diameter of the virtual basal ring of the aortic valve here on a zoom mode. The zoom mode also enables to see that the aortic cusps are thin and they seem to open fully. And we can also see the membrane in the outflow tract, which is not clearly visible because, as you can see, the membrane is parallel to the ultrasound beam, and in this case, the definition is not good. So here you can see a little better the membrane, but still not clearly visible. And if you change the plane to go on the border of the outflow tract, you can see a little bit more easily this membrane in the left ventricular outflow tract. Now we will use the color Doppler flow to image the fact that this young patient has an aortic regurgitation, which seems moderate at first sight. We will zoom on the left ventricular outflow tract, and the Nyquist limit is between 0.6 and 0.7 meter per second with a symmetric baseline in order to measure the vena contracta. So we'll stop the image for measuring the vena contracta, and here we can see clearly the pisa and the narrowest zone, which is the vena contracta, which we will measure here. So the first measurement is around 3 millimeters. We can check another one. And here the second measurement is also 3 millimeters, which supports mild aortic regurgitation. Now we have changed the view. We are still in zoom mode on an en face view of the aortic valve, just to check that we have 3 sinuses of Valsalva, 3 cusps, and most importantly, 3 commissures that fully open to exclude a bicuspid valve. And this is the case in this young man. Here we can freeze the frame in systole, and you can see that the 3 commissures fully open, so this is not a bicuspid valve. Now we can check the left ventricle in the transverse parasternal view with a contraction which seems fully normal, and then we will go to the apical views. So here we begin with an apical 4-chamber view. And as you can see, the left ventricular systolic function seems perfectly normal and homogeneous in this patient. Afterwards, we'll change for a 2-chamber view, and also the systolic function seems perfectly normal. We can also see that the mitral valve is thin with a normal motion. And at last, with this 3-chamber view, we begin to see the membrane in the left ventricular outflow tract better as compared to the parasternal view, because in this case, the structure is perpendicular to the ultrasound beam, and so the definition is much better. With the color Doppler, again, we see the aortic regurgitation with an extension, with a relatively short extension in the left ventricular outflow tract, and we also begin to see a convergence zone in systole with the acceleration of flow at the level of the subaortic membrane. If we go to a modified 4-chamber view, now we can see clearly the membrane in the left ventricular outflow tract here, and a little bit lower you can see clearly the aortic valve, which seems to open normally, which is not thickened, with no calcification. Here again we can see perfectly the membrane in the left ventricular outflow tract, and if we looked with the color Doppler, again we can see the small aortic regurg in diastole and the acceleration of the flow at the level of the membrane in systole. We will check the left ventricular filling pressure in this patient, and here we put the pulse wave Doppler at the mitral inflow, and we will stop the image to measure the E wave, the A wave, and afterwards we will look with the tissue Doppler here in this patient, and we will check the E prime wave on the lateral part of the annulus, and here we have the tissue Doppler on the lateral annulus and the measurement of the E' wave, and you can see the E to E' ratio, which is around 6, which supports normal left ventricular filling pressure in this patient. Again, we go to the apical modified 4-chamber or 5-chamber view, and we will check the flow acceleration and the level of the flow acceleration with the pulsed wave Doppler. And as you can see here, we will begin with the pulsed wave Doppler sample above the membrane. And here we have a nice laminar flow with a relatively normal speed. And here, if we stop, we have a laminar flow with a closing click, and we go down progressively to go at the level of the membrane progressively, and here we have an acceleration of the flow just at the moment when we cross this membrane. So now we will use the continuous wave Doppler to have the global gradient across this membrane. First of all, we also have the combined flow of the diastolic flow of aortic regurgitation and the systolic flow of the membrane. We will check the systolic flow with an automated detection system, which enables us to calculate the mean pressure gradient and the peak pressure gradient. As you can see here, the mean pressure gradient is 26 millimeters of mercury with a peak velocity around 3.3 meters per second, which supports mild obstruction in these patients, as we consider that severe obstruction for a subaortic membrane is when the mean gradient is over 50 millimeters of mercury. We will go back to the diastolic flow to measure the pressure half time of the aortic regurgitation. And as you can see here, the pressure half time is 367 milliseconds, which is long and supports mild aortic regurgitation. As we can remember that a pressure half time shorter than 200 milliseconds supports moderate to severe regurgitation. Now we will change the position of the patient, who will be flat on his back, to image the suprasternal view. And here we will check the diastolic flow reversal for the aortic regurg. Here we are in a good position with a pulsed wave Doppler sample at the level of the aortic isthmus. We will take this measurement, and the results gives 14 centimeters per second, which again supports mild regurgitation. We know that for moderate to severe regurgitation, we would need to have an end diastolic velocity above 20 centimeters per second. At last, the patient will roll on his right side, and we will image the right parasternal view, which is very useful to check if we don't have a higher velocity in this position. And it's very useful to use the dual probe with the imaging probe. It's much faster to align with the flow. And as you can see here, the Doppler beam is perfectly aligned with the flow. And we check with a continuous wave Doppler the peak velocity, and we also measure the mean gradient. We had 3.3 by the apical view, and here we only have between 3.1 and 3.2, which is lower, and so the maximal velocity was recorded in the apical view. And at last, we can measure on the apical views, calculate the left ventricular volumes with this automatic detection system that also gives the longitudinal strain in the 4-chamber view and the 2-chamber view. And as you can see, the left ventricular volumes and diastolic volume is 150 milliliters, which is the upper normal in this patient, and the ejection fraction is normal at 58%. So to conclude, this young patient has mild subaortic stenosis with a mean pressure gradient around 25 millimeters of mercury. He also has normal LV function, a non-dilated aortic root. The left ventricular filling pressures are normal, which is coherent with the fact that this patient is strictly asymptomatic. So the management of this patient is to follow him and to repeat the examination at 1 year.
So the key point of this examination is that we have to use multiple views, not only to look at the membrane, but also to look at the flow and to quantify them appropriately.